Thank you, everybody, for joining us. My name's Barry Monroe. I'm the treasurer of the North American SCI Consortium. Actually, we have with us today, too, our president, Ian Burkhart, is joining us. But we are lucky to have Jeff Thompson, who works with Synapse, who are our gracious sponsors of helping both NASCIC out and really promoting respiratory care and helping bringing knowledge to people with lived experience and how we can live our daily lives, as well as clinicians understanding more of the intricacies of respiratory care. And so we've taken this opportunity today to create a program called Office Hours, where we'll have Jeff speak to various topics, but also more importantly, that you're available to answer questions that people might have around respiratory care and spinal cord injury. And we must be very clear that we are not offering any type of medical advice today. If anybody has any medical questions, that they should take that to their designated clinical advisor or family doctor to get that information. So this is not medical advice being offered today, but really more about some knowledge sharing on spinal cord injury and respiratory care. On that note, Jeff, take it away, and it's all yours.
All right. Thanks, Barry. And thank you to those that have logged in. I'm going to go through some of the slides. We had some questions that were presented prior while we were assembling this. So I'm going to start with those questions first, and then we'll build from there. Conflict of interest disclosure. This is all the legal stuff I have to get out of the way. My name is Jeff Thompson. I'm a registered respiratory therapist here in Cleveland, Ohio. Been a respiratory therapist for 30 years, working in the spinal cord community for about 25 years. And I am currently the clinical services manager here at Synapse Biomedical. I am a direct employee of Synapse, and I am a non-major shareholder in the company. So the objectives for this talk, first of all, it's intended to be an interactive discussion. I know I said that I've got some questions that were presented that I'm going to start with, but if you have any questions, please feel free to ask during the presentation. And if you have some experience with some of these topics and you have some secrets or techniques that you found to be helpful, we encourage you to share them. As Barry mentioned, that this is intended to provide information regarding respiratory health for people with spinal cord injury. The information is not, it's just general purpose information. It's not here to replace a physician. So if you have specific questions about your health and your care, always consult with your physician and healthcare providers for medical concerns. So I'm going to start off with a question that was asked, and I'm going to be honest with you that this is done infrequently, and it probably should be done more frequently, in my experience. And then the question was, please describe what breath stacking technique is and why it's important for people with spinal cord injury. So breath stacking is a specialized technique where a person takes in slow, deep breaths, or slow, repeated breaths, not real deep, and you add or stack each breath on top of itself. So your first breath, you start to take in a breath, your abdomen pushes out, and then you stop, and then you take in some more air, and you stop, and then you take in as much air as you could possibly fill up your lungs with, and you hold it for 3 or 4 seconds, and then you exhale through your mouth. Okay, this is usually followed by a cough. It's basically a secretion clearance technique and helps in the prevention of lung collapse, which is called atelectasis. So the interesting thing about breath stacking is that it can be done with or without equipment. Without equipment, I've outlined here the steps to do that. It's just sit comfortably as best you can, loosen any restrictive clothing. When we talk about sitting comfortably, ideally your feet are flat on the floor or on the rest of the chair. You are as upright as possible. We don't want you slouching. That's the big key in doing this with or without equipment, is try to set up as straight as you can. If this technique can also be used in a reclined position, it can also be used in a supine or lying condition while you're lying in bed. But what we don't want is the shoulders slouching forward and kind of hunched up, because that prevents you from taking a deep breath. So again, loosen any restrictive clothing, taking a full breath using your nose, allowing your stomach and lower rib cage to expand outward. Then you take a smaller second breath and hold it. And then you take a third breath until your lungs are completely full. Hold it for 2 or 3 seconds, let the air out, and then rest for about a minute and then repeat it. Ideally, it's done 3 to 5 times in a what we call a session. If you want more information on it, YouTube is a great place to find stuff. You search breath stacking, and there's an example on the slide here of someone doing breath stacking, the technique of breath stacking. Now, interestingly, you can also do this with a manual resuscitator and a face mask or a mouthpiece. This is considered what we call a mechanical breath. Again, you're sitting upright as best you can. As mentioned, it can be done, adapted for reclined or in a lying position. But again, your shoulders shouldn't slouch forward because that restricts your rib cage. You or a caregiver holds a face mask firmly around the nose and mouth. If you're unable to hold it independently, again, your caregiver will do it. It can also be done with a mouthpiece. And then as you start to take a breath in, the caregiver squeezes a manual resuscitating bag. And you fill up your lungs, but don't breathe out. And then you stack another breath on top of it. And again, each breath is not a complete squeeze of the bag, if you will. It's just to fill you up a little bit, about halfway, 3/4 away, then put another breath in, then put a third breath on top of that. Again, holding it for about 2 or 3 seconds, remove the mask or mouthpiece, and then exhale through your mouth. Again, if you're noticing that you're starting to bring up secretions, you can cough them out, you can suction in between. So it's just a really good method of what we call hyperinflation and secretion clearance for people that are with spinal cord injury. A second question that was asked, is there some resource where I can find how someone can assist with cough? And I just kind of spilled it on that last one. YouTube is a wonderful resource of finding information. And I just listed some just on manual assisted cough here that I found just by searching the terms manually assisted cough. Another resource, the Christopher and Dana Reeve Foundation, they have a wonderful website that has tons and tons of information. I'm sure you can just Google search and you will find even more information out there on the interweb. Question 3 that came up. My understanding is that people with tetraplegia have difficulty with their cardiovascular exercises that would increase their heart rate. Is this the same for respiratory health, and are there exercises that would help strengthen one's lungs? So before I change the slide, is that yes, it is difficult for people with tetraplegia to increase their cardiovascular exercise. Because of the level of injury that you have, it's difficult for the body to respond to changes such as cardiovascular exercise. For some people with high-level tetraplegia that can't control their breathing, they don't have a natural way anymore to increase their respiratory rate or take deeper breaths like someone would if they're exercising that doesn't have spinal cord injury. There are methods around that. I do know of patients that on the ventilator, they will use, for example, an FES bike, but they have permission from their physician to increase the respiratory rate while they're exercising to get rid of extra carbon dioxide that builds up when exercising occurs. Having said that, the second question, which is even more interesting to me, is it the same for respiratory health, and are there exercises that would help strengthen one's lungs? And ideally, you're not strengthening the lungs, you're strengthening the muscles that surround the lungs. So it's called respiratory muscle training. And there are 2 different types of devices that act very similarly, but uniquely. The first category, if you will, are called inspiratory muscle training devices, or IMTs. These are all small handheld devices that offer resistance against inhalation. So it makes it difficult for you to take a breath in. What that does is that exercises the muscles that are responsible for taking a breath in, your diaphragm, your rib cage muscles, things like that. And I've listed some devices here that I found on the internet that are examples of inspiratory muscle trainers. It's not an endorsement for one or the other. It's amazing, again, when you get on the internet, what you can find. The other category are expiratory muscle training devices, or EMTs. Again, another small handheld device, but it offers resistance against exhaling, usually with a valve or something that obstructs your ability to exhale. You try to push air out of your lungs as hard as you can, but the device offers resistance for it. Some examples of devices that do muscle strength, expiratory muscle strength training are listed here. One that's also interesting there is the Acapella. I've used that in my career, and it's a very good device that offers also what's called positive expiratory pressure training and vibration to help with secretions clearance. So it's another one of those devices that can do two things. One, train your muscles better, and two, help with secretion clearance. But for any of these, I'll be very honest with you, the world has found out, you can find anything on Amazon, but talk to your healthcare team to see if something like this is appropriate for you. Question 4 that came up in preparing this presentation is, are there apparatuses that could increase somebody's breathing capacity, something like an abdominal belt? And actually, yes, there are. Abdominal binders are recommended for people with spinal cord injury in wheelchairs, especially the higher level spinal cord injuries that have lost their muscle tone in their abdomen. The binder helps prevent pressure from the abdominal contents on the diaphragm, so it helps keep everything in place so the diaphragm can do its job. It's helpful to wear the binder when you're sitting up, especially when the early phases of the injury. So you're getting used to this loss of muscle control in your abdominal area, in your chest area, and you're getting these things to where you can use them to hold your abdominal contents in place, and then it offers support for that. But please know that binders are not recommended for when you're in a supine position. You don't need it because your abdominal contents naturally move out of the way. Question 5 is, what can I expect in terms of respiratory function as my condition progresses? And I found this to be very interesting because, like everyone, even people without spinal cord injury, there's a decline in respiratory function as we get older. It's well documented that respiratory complications are actually one of the leading causes of mortality following spinal cord injury. I believe urinary tract infections and sepsis is crawling right up into that same category as well. But there are several factors that can contribute to a high rate of respiratory issues for people with spinal cord injury. The first and the primary one being your level of injury. The higher the level of injury, the more challenging it is for your breathing. The level of injury changes the breath mechanics, because if you lose control of the muscles for that, what you have is the muscles become weak or they atrophy, and this changes the entire mechanics of your breathing. There's also reduced elasticity in the chest as more time passes after injury. It's just simply the lack of use of these muscles. They just get weak. Diet and weight are a huge problem for people with spinal cord injury. I remember one young man that I took care of in my days of doing home care. He was injured at 18. He was 6'1". He weighed 180 pounds. I attended his funeral 3 years later. He weighed almost 400 pounds. And in talking with his family, eating was the only thing he could control. He would complain he was always hungry. I want to eat, and the family would feed him. That's bad because it adds a lot of weight to the abdomen and chest, and it makes breathing more difficult. The reduced level of activity also contributes to the rate of decline of your respiratory function. Again, the muscles that aren't used, the old saying, if you don't use it, you lose it. And then smoking and or vaping. I've noticed that people that are injured for lower level injuries, thoracic or lumbar injuries, for example, that smoked prior to injury, they continue to smoke. And again, that's not a good thing. So some preventing mechanisms or preventing tips to prevent the decline is monitor your color consistency and amount of your secretions. This goes for regardless of your level of injury. If you know, what you cough out will tell you if you're getting sick or not, honestly. You'll notice the color of it. If it gets really thick or it turns green or yellow, these are all indications that you have some type of respiratory infection going on. You want to avoid buildup of secretions. If, again, going back to the hyperinflation and some of the other topics that we started with, hyperinflation, secretion clearance are very, very important. Stay hydrated. I know that gets inconvenient for some, but hydration is a big part of keeping your lungs healthy. This one's kind of tough. Stay away from people that are sick. I have family members that come over and they don't know they're sick until like the day after they've stopped by the house. And what ends up happening is, they call and say, "Hey, just want to let you know, I've come down with this, for lack of, we'll use an example for COVID. I just tested positive for COVID, but they were fine when they were at my house." So if they know they're sick, stay away. Maintain a healthy weight. Don't smoke if you can. I know that's a very hard habit to conquer. Consider yearly flu shots and pneumonia shots, and then communicate with your physicians early and often. I saw a patient a couple of years ago, and we went out to make some adjustments on their diaphragm pacing system, and then he revealed to me he hadn't seen a physician in 6 years. And that's not good. You have to have a relationship with some physician in your community, whether it's your primary care physician, a pulmonologist, physical medicine rehab, someone that you can go to. If you get sick, they know how to handle it, and they know about you. This one came up in the discussion that Barry and I had, that are there clinical trials for people with spinal cord injury? And I went on the internet yesterday, because that's a great place to find stuff. Clinicaltrials.gov is where people register clinical studies. And if you search using spinal cord injury, I found that there are 217 active trials right now for spinal cord injury that are currently enrolling or recruiting people to be in their study. I listed just a few of them. Obviously, 217 would take up a lot of time, but there's some interesting ones that I don't have here. One that I found very interesting was living longer and stronger with spinal cord injury. I didn't dive into exactly what the study was, but that one really, really intrigued me. You can search these by whatever state you live in or whatever country you live in. You can filter out studies from other countries. There are a number of them I filtered out from China and Switzerland. But if you want to go over there and enroll in a study, that's fine too. I actually have had a couple of patients that have done that over the years. But these are some of the interesting things that you can participate in to help the medical community find ways to help those with spinal cord injury. So those are the topics that I was presented with prior to this. I'm going to stop sharing my screen, and then if there have been questions asked, I don't know if Barry, if they're in the chat, or they can just start asking questions.
Yeah, so we'll ask everybody, if you have any questions, feel free to raise your hand. Or if you don't feel like asking it verbally, put it in the chat. But Jeff's here for you, and really, I don't think there's no question that's stupid, right? There's all good questions out there, and I think that's great. I noticed that one extra piece there, Ian put in the chat group that there is a more refined database or link to seitrials.org that is really looked at clinicaltrials.gov, but also brings a bit of a twist that is more personal lived experience focused, and it helps people understand things in the abstract too, and it brings summary to it. Ian's got a question.
Yeah, hi Jeff. Thank you so much for that good presentation, and it really simplifies a lot of information that I think a lot of us have probably heard over the years through various hospital admissions or from various doctors and therapists, but really hits home some of the things that we need to pay attention to. I noticed when you were mentioning about the devices that you can use to help improve your respiratory strength. What about like the inspirometer that everyone gets after being intubated or under anesthesia. How well do those devices work? And, it seems like that's always a good, like, the nurses come around like, hey, have you been doing this? And most people probably don't.
Yeah.
And they don't really push too hard on it. But how important is that for someone with a spinal cord injury?
That's a great question. Thanks, Ian. It is the simplest device to use, and like you said, we all get it if we've been in the hospital, regardless for surgery or not. It's one of the things that is easily and readily available, but it's also often one of the most misused devices out there. I remember my father after he had cardiac surgery. I was trying to coach him through doing it, and all he would do is take a quick deep breath in, it would ball would go straight to the top, and then he would stop. And I'm like, no, that's not how you're supposed to use it. And he said, well, I'm doing this just so they stop asking. Okay, but doing it correctly, and oftentimes it's not well taught. In certain places, it's taught actually before surgery, which is a very, very great thing to do, because then the person is familiar with it. But if you get one of these from the hospital, take it home and use it. It's just simply you put a mouthpiece in, or someone holds a mask over your face, and you just take in a slow, deep breath, trying to maintain a certain level of inspiration, if you will. There's always marks on it and the clinicians will set, here's your goal. And it's not just simply take a great deep breath in and then relax. It's a slow, deep breath, as slow and deep as you can while holding the ball or the piston in a certain location. And it's a very, very simple device. And I think just about every drugstore has them too. So it's a great, great device to be used for sure.
Thanks, Ian. So Jeff, how long have you been working in this area as a respirologist?
So here in the United States, we have respiratory therapists. I believe up in Canada, you have physios. Is that correct? And respirologists.
We have respiratory therapists too.
Okay.
Yeah.
It's Europe that has physios. Sorry. I started late. I was a late bloomer, actually. I graduated college for this when I was 31. Yeah, 31. And I started out in the neonatal intensive care unit here in Cleveland at the Cleveland Clinic. It was actually had just opened, and we were doing some really, really interesting work. We were doing open heart surgeries on hypoplastic left heart patients at 1 and 2 days old. And that was a real eye opener for me. Then I transitioned into the pediatric unit. We just needed more therapists over there. Then transitioned to the adult side when the pediatric ICU was slow. And then I got into home care. Found working with people at home was more satisfying for me, because I realized early on in my career that that's a part of keeping people home that was missing, is taking the time to teach people how to use their oxygen correctly, how to take their breathing treatments correctly, following up with them to make sure that they're using their CPAP device or their BiPAP, and did that for a very long time. And then I got recruited to go back to the hospital and work in management. Did that for a while, then got into clinical research, and that's where I really felt I belonged. Started doing research on respiratory drugs for COPD, some other devices back, oh geez, this was 20 years ago. There were drugs that were just coming out back then that are no longer used, but they found better ones. And then we housed Christopher Reeve when Synapse Biomedical implanted him with his diaphragm pacing system. Ironically, he was implanted at university hospitals in downtown Cleveland. That's where all the media was. But I worked in an inner city trauma hospital here in Cleveland, and we had a very nice research unit in the basement, and that's where he stayed, because one of the physicians involved early on with diaphragm pacing was also on staff at Metro Health. So got some exposure to the device, and I applied for a job here, and I've been here for 17 years.
That's great. Last year we had a great webinar discussing diaphragm pacemaking, and we should remind people that are watching today that it's available and archived on our website at NASCIC.org. And it was a great presentation, very well received. Your participants were fantastic. The knowledge that people gained from that were great. And I think, Ian, you might have attended to, we attended Unite to Fight Paralysis Symposium in 2019 in Cleveland, where we also hosted our NASCIC annual meeting. But at that time, we had a great opportunity to see all of what's going on in Cleveland in terms of the various works in FES and such. And one, of course, was diaphragmatic pacemaker. And the thing that was interesting that came out is, and to maybe the people outside of our community to understand, that just the ability to cough, that people take for granted so much, and how important that is. And so someone like myself, being a quadriplegic, I've had pneumonia. It's really a very scary moment when you're having problems coughing and frankly discharging phlegm, trying to get your lungs clear. You literally have to sit up all night. You can't lie down. You don't feel safe. And I'm lucky. And I can think of my levels of C5-6, what it's like for someone of a higher level must be even harder. And I go out to you, Jeff, and what you do and help people. Maybe explain a little bit more about diaphragmatic pacemakers again, and for those that it might be more new to them. And frankly, it's something that I don't think enough of us know about in the community.
So there are two styles of diaphragm pacemakers currently available in the United States. One being the Avery device, that is a phrenic nerve stimulator, where they attach an electrode directly to the phrenic nerve. The other one is the Neurex diaphragm pacing system that's a company that's Synapse Biomedical that I work for, where we implant 4 electrodes into the diaphragm muscle itself. One of the key aspects, regardless of device, is that you have to have an intact phrenic nerve for the device to work. And that's imperative, because if the nerve doesn't communicate the signal across the diaphragm, then the device will not do its job. So that's number one. And we're often asked, for the Synapse diaphragm pacing system, how do you determine if somebody's phrenic nerve is intact? For us, the easiest and the most definitive way of knowing is to go into surgery, do a diagnostic laparoscopy, and we actually touch the diaphragm with an instrument and stimulate it. If it moves, we can move forward with implanting. If it doesn't move, we know the phrenic nerve is damaged, and then we stop there. If there's other medical procedures that are being done simultaneously, they can continue with those. But what that also does is allows the hospital and the family to start planning long-term ventilator strategies for them. The hospital can stop trying to wean the patient off mechanical ventilation because the diaphragm just will not work. And both devices are designed to wean people off mechanical ventilation onto these external devices. And both of them do a really, really good job when used properly. That's a key. Again, it's not for everyone, and I'm sorry it's not. But if the nerve doesn't work, there's nothing that can be done, and that's the key factor there.
It's good to know, and it's exciting that this is something that's available that didn't seem to be mainstream many years ago. So it's great.
It's gaining more use, especially after acute trauma, after early injury. For our device, the Neurex device, it's being used in a lot more trauma centers very early to wean patients off the ventilator and get them out of the ICU, because the last place you want to be is in the ICU, because that's where the sickest people are. And so if we can get you off the vent and get you out of the ICU and into rehabilitation, and get you access faster to that, start the recovery process, that's a huge goal.
My understanding too is that there's still a lot of education that needs to be put forward to the trauma specialists and the clinicians that of this opportunity. In our experience in Canada, which is not unlike the model centers, for example, that when somebody comes in that requires a respirator, it seems like everything else falls off in terms of rehabilitation. They're treated, they're put on a vent, and that is it. Like, and so they miss out on all the things that are necessary as part of our natural rehab, that everybody else has available to them. That they're preoccupied, and I mean, it's not saying it's a bad thing, but they're really focused on the breathing aspect of it, but they let everything else slide. And I think my understanding is with a diaphragmatic pacemaker, there's the opportunity of potentially doing more on the rehab side, and not being on the respirator, which is good for their general health in general. That's my understanding. And if I'm wrong, let me know.
Yeah, here in the United States, rehab centers are, let's see, I have to be careful how I say this. It's less common for rehab centers to accept patients on mechanical ventilation, because patients on the ventilator are considered more labor intensive for the facility. That's number one. Number two is, here in the United States, the facility gets reimbursement by the number of hours of rehabilitation you can do. And patients on mechanical ventilation, it's a little more difficult to get those hours in because of, needing to take the ventilator from your room to occupational therapy, or, to some type of group situation or group therapy session. So the diaphragm pacing systems, what those allow you to do is, it allows, if we can wean you from the ventilator onto the device, it makes transport, it makes everything so much easier as far as a management point of view for the facility to manage the person.
Understood. Just going to ask everybody, does anybody have any other questions? I will remind everybody that this will be archived, on our website after this conversation, and we will then, for those that did participate, you will get an email sending you a copy of the presentation. And we really would like to encourage everybody to share it with anybody you can think of.
Yes.
That might benefit from this information. Just that those bits are things that, Jeff, they're almost like nagging questions that we sort of pick up over the years, but no one really has answered it because we never might not had the opportunity to sit down and ask those questions to somebody that could answer it. So this was a great opportunity today to hear your answers and your guidance there. Ian has got a question.
Yes.
Yeah, Jeff, I have another question for you. You mentioned previously about compliance of individuals using CPAP, and I know that that's definitely a challenge. My mom rarely uses hers, and she definitely should. But just thinking, even personally, but also for other individuals with spinal cord injury, that's generally something that progresses more and more as you age. Is it something that's more common in someone with a spinal cord injury because they already have a compromised respiratory system? Or is that, just more of a hereditary and other indication issue?
Well, it can be a hereditary issue, but what ends up happening there, I call it a spiral effect, if you will, for these folks. What happens is, because you're less active, you start to put on weight, and depending on your level of injury too, you could lose muscle tone in the throat, which is the major cause of sleep apnea, obstructive sleep apnea. So to increase compliance, if you will, it is a very, very difficult process for some people. I've had people that have received a CPAP, and night one, they slept a whole night, they slept great, they loved it. And then 3 weeks later, they can't stand it. And it's just something that you have to commit to and get used to. I know it's very difficult, but once it gets dialed in and all the nuances of using these devices are addressed, things like humidity, having a heated humidifier helps. If you're claustrophobic, they make different masks types, either just on the nose instead of over the nose, or they make a full face mask that you can see out of, that's full of, that the pressures pump through. But it's just working with your home care provider and your physicians to find the right combination of devices or, masks, settings, those kind of things to make it comfortable for you to use. I know it's not because you're tethered to a machine. This light sits next to your bed. I can tell you this much, Ian, they've come a long, long way in improving these devices, making them quieter, making them smaller. It's just for people that have sleep apnea, obstructive sleep apnea especially, it's just a challenge that you have to commit to doing it. I know there are new devices out there, implantables now that stimulate a nerve to keep it open. But that's an option for a spinal cord injury patient as well. That I don't know if many spinal cord injury patients are aware of these types of devices for sleep apnea, but it is a fully implantable device. I think it's either basically an on-off device that you hold over the implanted device. You turn it on and it senses if your airway starts to close. It provides electrical stimulation to the nerve to pull the muscle back to keep it open. It's really some phenomenal technology that's out there. And it should, if you cannot tolerate the mask and you cannot, and they've tried everything, they've tried CPAP, they've tried BiPAP, the humidifiers, 3 or 4 different masks, definitely look into the fully implantable option because I have a friend that has one and he absolutely swears by it. He said it's a complete life changer for him.
That's great. We do have a bit of time. Is there any other questions out there? Covered a lot, Jeff, in 40 minutes. And again, I urge people to.
It's amazing how much I can talk after just 6 questions.
Oh, it's great. It's great. Imagine we had 7.
Yeah.
Well, I think for today that was a great start. I think the information you got out there was fantastic, and again, urge everybody on this call to share this information once we send it to you, and urge people that have any respiratory questions to go to that piece. And what we'll do, Jeff, when we send it out, we'll have your contact information as well. Yep. If they want to reach out to you, if you're okay with that. And and I think what you're sharing is so important and something that we all can really benefit from. But really on that note, I think our office hours are over for today, and we will come back in the future once we feel that there's a host of more questions or to review what the questions we've already talked about. So again, I urge everybody to share this with whoever they can. And if there's any feedback on this session or any other sessions, please let us know. It'd be great to hear from you. And we appreciate everybody for attending today. And most importantly, Jeff, thank you so much for sharing your knowledge today, and our friends at Synapse for putting this on. And really do appreciate it.
Barry, thank you and Ian both, and NASCIC for putting this together. It's so important to get information out to people, or even provide an avenue to ask questions. So thank you for putting this together. I truly appreciate it.